it sounds like there's consensus that we would do platinum, pemetrexed, and pembrolizumab in this case. I think the question is, the trial was structured to give 4 cycles of platinum pemetrexed and then the option of maintenance pemetrexed. Are you guys doing maintenance pemetrexed with the pembrolizumab? Are you dropping the pemetrexed?
I am. You know, it's up to, I think, 35 cycles. So I do that, but there have been a couple of cases where I did drop the PEM because of refractory anemia.
Okay.
So, and I just continued the pembrolizumab out.
Yeah, for this patient, I would give them 4 cycles of triplet therapy. I'd drop the carboplatin, and I'd probably continue the pemetrexed and the pembrolizumab, PEM squared. And, you know, I think that's generally, there may be some synergy with these 2 drugs, obviously, that we're seeing in the triplet regimen, but maybe it's really those 2 drugs put together that is you know, causing this benefit or driving this benefit. We don't know. So that's what, in this patient, I would do. I would do 4 cycles followed by maintenance PEM, indefinitely until disease progression or not tolerating the drugs.
Mm-hmm. I think it's really the toxicity profile and how the patient's looking. That really makes my decision. I try to keep the pembrolizumab as a preference, and I'll usually drop the pemetrexed if I have to drop one.
Right.
What about at Memorial?
So we were holdouts based on the Keynote 21G data. We did not put that into play, but with 189, we're routinely doing this. And I tend to agree. I mean, the trial was structured where maintenance pemetrexed was allowed. Most patients, you know, had some amount of this, and I think you can't discount the fact, I think, as you mentioned, Ben, that there's some interaction between that and immunotherapy. And if anything, the chemo IO era tells us that that's the case. So we try to continue it for as long as possible. I think the last question I want to ask here in this case in the time that remains is something that's also clinically relevant. We have a very symptomatic patient here. What if the PD-L1 expression was high? What if it was 70% or 80%? Mm-hmm. We know from the 24 data that pembrolizumab single agent is an option. How would you give that? Would you give chemo IO?
You know, yeah, that's like the big question right now, right? What do you do in the high PD-L1s? And honestly, what I advise is that if there's somebody who is asymptomatic, you know, relatively, you know, has tumor disease burden, but is not imminently threatened, then you can take the time to give single-agent monotherapy pembro. I tend to think the monotherapies tend to not debulk the tumor as quickly as when you use a triplet regimen. But in this case, we have a patient who is symptomatic. They appear to be ill. They can still have a good enough performance status that they could tolerate the triplet. And I think just because of the symptoms, I would actually go with the triplet because that has the highest response rates in the high PD-L1 population when you look at the data from 189.
I agree. I think that treatment decisions have to be individualized. If a patient's PD-L1 is greater than 50%, you have the option of single-agent pembro versus triplet therapy. The benefit was across the board. The hazard ratio is a little more robust for the triplet in the PD-L1 greater than 50s than 024 is for the, obviously everyone was greater than 50, but I think it's individualized. If you have a symptomatic patient, maybe I would use triplet therapy. If they're not so symptomatic and you think you got a little time, I'd just give them single-agent pembro.
But then I had a 92-year-old come to my clinic the other day, and he's 80% PD-L1 positive. Yeah. So
yeah, obviously patient.
I went with pembro alone.
Yeah,
right. Yeah, and I think that's what I would have done. So I think that's it, but I think I'd like to close for this case by just noting that it's a great time, I think, right now, this first-line setting for non-small cell lung cancer. There are some things we have to work out, but the options that we have are options that really have moved the bar in terms of overall survival. So I think there's a great deal of optimism now and going forward to look at, yeah.